thanks. Pleasure to talk to you today. So I'm going to start with an introduction to cognition and dementia. Then Tanja is going to talk to you about how common dementia is in Parkinson's and some of our adventures with online testing of cognition. And then I'll tell you a bit about prevention and treatment. So dementia is a horrible word. It's terrifying to a lot of people. But technically, it's an umbrella term for a range of conditions. All of them cause memory loss and problems with thinking, which we call cognition. And part of the definition is that they need to be severe enough to affect daily life. And in general, they're progressive. They are neurodegenerative, which means that the brain cells are dying. And with all of them, there is no cure yet. The commonest dementia is Alzheimer's disease and has a different pathology, a different kind of protein. The second commonest is vascular dementia, which is actually related to heart attacks and strokes because the blood vessels get thinner. And the one that's important for Parkinson's disease is called Lewy body disease. There are a range of other rarer dementias too. Now, cognition is a collection of abilities that our brain has, and it just means thinking or computing, because the brain is actually working things out all the time. But thinking is actually made up of many different components, and each of these components is roughly localized to a bit of the brain. But they all have to mesh together to make our internal mental life. And so we sometimes split cognition into these components. For example, executive function means our ability to plan ahead and to reason. Attention and working memory mean our immediate focus and picking up information. Language is our ability to process words, understand meanings. Memory means recalling things in the past, of course, and visuospatial is just my ability to pick up this cup when I see it. And all of these are brain functions. And the reason we like to split these things up is because they're affected differently in different diseases. For example, in Alzheimer's disease, typically patients lose their memory for events. They can't navigate. They have visuospatial problems, and they get disoriented in time. And in contrast, the Parkinson's spectrum of disorders lead to loss of immediate memory. People become inflexible. They have difficulty with planning ahead. Attention fluctuates. They can become impulsive or apathetic, and visual hallucinations are common. But in the late stage of all dementias, there's a lot more overlap, because ultimately the whole brain becomes affected. We have a lot of complex names in this field. The things that you might want to remember are, can you see? So Parkinson's disease with mild cognitive impairment is the first step towards Parkinson's disease dementia, when it really starts to affect your life. But if you develop these symptoms within 1 year of diagnosis of Parkinson's, we actually call it something different. Pretty arbitrary, but we call it dementia with Lewy bodies. And all of these conditions are confusingly lumped together to be called Lewy body dementia or Lewy body diseases. And you may know that this REM sleep behavioural disorder is this very early symptoms that can ultimately progress into Parkinson's disease with dementia or Lewy body disease. And the reason for all these distinctions is because the pathology that underlies it, the proteins that are causing these diseases, may be different. And understanding these may be key to developing the treatments.
Yeah, so I'm going to talk about measuring dementia in PD. And I'm going to have two short parts to my presentation. First, we're going to look at how common dementia really is in Parkinson's disease. And the second part will be about some new cognitive testing to detect very early subtle changes in cognitive function in PD and RBD. So the first part is mainly motivated by this paper that came out very recently, that is early August 2024. And this is from a team working on the PPMI cohort data. And they've evaluated their cohort data to check how many people developed dementia over the course of the disease. And while, of course, there are really elaborate ways of testing all the different cognitive domains Sanjay just mentioned, and every cohort study uses their own combination of these, depending on what they are most interested in, there's also some very simple measures which we have in almost any cohort study. And two of these are this Montreal Cognitive Assessment, called, or short MOCA, which is something that all of the study participants here will have done once or many times. And another part is a really small part of the MDS-UPDRS1, to just ask the participant or their caregiver about how they feel cognitive impairment affects or doesn't affect on their everyday life. Okay, so on the right-hand side, you can see you've got 4 categories for this information that we record there. You've got people who report absolutely no cognitive impairment. Then you've got situations where there's slight or mild cognitive impairment that only has really minimal, at most minimal interference with everyday life. And you've got people, of course, unfortunately, who report moderate or even severe cognitive dysfunction, and that would be cases which likely have dementia. So the very, very brief summary of what they published in this paper, the figures, numbers they found for their cohort. Let's keep it simple and just look at these numbers here on the left side. So in the PPMI cohort, at 5 years after diagnosis of Parkinson's, about 3% of people had developed dementia as diagnosed by the investigator doing the follow-up visit. And at 10 years, this rose to about 9%. So, but with this data, I started wondering, how does this actually look in the discovery cohort, so among the people that we've been following up for many, many years now. And what you see here on the bottom axis is the years since diagnosis of Parkinson's disease. And on this axis, you see how common dementia is in the group at the particular points in time. And this here, so this is just the PD participants we are following up, obviously, but we've grouped them a little further into those who were diagnosed with PD at an age of less than 60, 60 to 69, or 70 or greater. And if we look at the percentages of dementia diagnosis in these different groups, you can clearly see that those diagnosed at an age of less than 69 years have a much lower chance or much lower risk of developing dementia than those who are diagnosed at an older age of 70 or older. Similar, if you group the PD participants of the discovery cohort by their gender, you'll see that for PD dementia is more common in male subjects than in females, about twice as likely. And finally, this is grouped by cognitive function at your very first follow-up visit. So one group shown here had an excellent score in this MOCA assessment of 27 or greater, and the other group had a less excellent score. And you can see that in those with really good cognitive function at baseline, the risk of dementia even 10 years later is quite low. So there's a huge difference. And this is, of course, interesting because if we can identify certain factors, and these are obvious ones, age, gender maybe less obvious, but cognition at baseline obvious, then we can predict future risk of developing dementia on an individual level, because what applies to you might be very different from the average PD study participant. And what's also interesting here, so on the left side, you always see the diagnosis made by the investigator. And on the right-hand side, you see what's patient or caregiver reported functional impairment. And you can clearly see here in all the figures, this is very similar. So this also says that your own experience or the experience of those people around you is very similar to what a clinician would diagnose in clinic. So I guess all in all, you can trust quite well in yourself there. Just a final one on this. So just a quick comparison to the paper that I've shown in the beginning. This is the same figure as before, but just flipped. Yeah. So this is the chance of not developing dementia. So I just made it this way so that I can put it next to the PPMI plot here, by the way. And this is grouped by cognitive function at baseline. And you can see that for those who perform really well in terms of cognition at baseline, we get very similar results to the PPMI cohort. For those who perform less well already initially, we get higher percentages of dementia. And I think we already kind of know why we get these differences, which is that the PPMI group is in general younger at diagnosis than the discovery cohort. So there will be these groups, even though they are defined on the same criteria, are not the same at all. So that's also why it's quite important to look at individuals and not just at a group, because even groups can be quite different. You will have noticed that I've got this little preliminary results box in all the slides, which is because I did these figures last week, and there's a lot of statistical aspects that would be good to consider before really publishing this. So there's something called interval censoring, which means we only see you every 18 months, right? And it's unlikely that you've developed dementia if you do that exactly at that time point, but it might have happened somewhere within those 18 months. And there's statistical ways to account for that in estimating such figures. There's informative censoring, which means that likely those participants who are not longer in follow-up, or they are more likely to have developed dementia, because cognitive problems can be, of course, one reason why you might withdraw from a study. So that's something that a statistician would want to consider. And then there's also a project I'm currently working on optimizing or finding the best estimator of cognitive impairment and dementia from all the data we have in discovery, rather than just these simple ones that I've shown you. And then, as I said, further down the line, we want to, of course, clearly identify other risk factors apart from the ones that I've shown you already, and want to make individualized predictions of dementia. It's part of the prognostic index that Michelle had mentioned in the beginning. The second part is quite quick. So this is also very recent research. These papers have come out in spring this year, April, May, I think. And this is led by a group from Imperial College London. And they've developed online cognitive monitoring technology for people with PD and RBD. I think we've already heard a lot about smartphone and online technology to measure symptoms. And of course, the advantage is you don't need to travel to appointment. You can repeat it much more times. It's more cost effective, and especially with cognitive testing, I'd guess it's also less stressful if you do some tests at home rather than sitting in front of an examinator in the clinic. But saying that, it's absolutely not meant to replace face-to-face appointments. It's just a way to get more data at lower burden to patients and more cost-effective. And what this group has used is the Cognitron library. So there's this really huge library of cognitive tests, I think more than 100 tests, available online, also developed by Imperial College London. And this is how some of this looks. So some of these really have like a game-like appeal to them. So there's stuff with numbers, stuff with words, stuff where you have to move blocks around. And what this group working on data from you did is from these over 100 tests, they've identified 19 based on our knowledge and prior research on the cognitive domains affected in RBD and Parkinson's. Then, participants from our cohort study were asked to complete this test battery. Does anyone here remember doing this? Is there someone who's contributed? Yeah, quite a few. So in total, about 50 controls, 50 PD patients and 50 RBD patients did this testing. And this data was then analyzed by the team at Imperial. And they've used this data to identify the tests that are most sensitive to very subtle cognitive deficits in RBD and PD. So this is really meant to detect like these earliest changes that might not be noticeable in everyday life. Tests that are insensitive to device, because obviously you don't want different test scores if you do it on a smartphone or a tablet or a laptop. And also tests that are decorrelated. You obviously don't want to record very similar information multiple times. You want to have all the different aspects, but you don't want to do the same aspect many, many times. And out of this, they then got a reduced test battery that takes about 20 minutes to complete. Has these 8 tests here in it. And the bottom you see it, or they also compared it to these mocker scores, and they showed that it differentiates the groups better. So it's likely good to pick up the cognitive changes that are particular to Parkinson's or RBD.
Very quick and tell you a little bit about preventing and treating dementia. So the question is, can dementia be prevented? And the very simple answer is no. Some people have recently shown some evidence for modifiable risk factors, but it's important to bear in mind that there really isn't any causal evidence that changing these risk factors will reduce the risk of dementia. They're all associative studies in general. So in early life, less education is associated with dementia. In midlife, hearing loss, cholesterol, depression, head injuries, physical inactivity, diabetes, smoking, blood pressure, obesity, and alcohol are all associated with later onset dementia. And in late life, social isolation, air pollution, and visual loss have been associated. But just to reiterate, we don't know if these are causes. For example, social isolation, maybe it's just a very early symptom of the dementia. Or maybe education is just masking some of the mild dementias. These are all open questions we don't know the answer to yet, and more research is needed. I mentioned that dementia is not curable, but we can treat the symptoms. So here's a meta-analysis that we've been working on. We reviewed 300 papers on treating dementia in Parkinson's. And we found that a drug called rivastigmine was the best at improving cognition overall. The cognition is only one part of dementia in Parkinson's disease. So next, we're looking at neuropsychiatric features, which are also very commonly caused by the neurodegeneration in Parkinson's. So these are things like depression, anxiety, sleep problems, and behavior change. And what we're looking at is what drugs can best improve those. So that's, again, something for future research.
Our final slide we've got, or Maria from Imperial has kindly set this up last minute. So whoever has a mobile device and wants to try some of the online cognitive tests that I mentioned can scan this QR code in the top corner there. And it's just really like a 2-3 minute version to have a little play around how this works.